welcome back to Timeless Topics. In this episode, we discuss everything from the rise in distrust in medical professionals and standards of care to building safe relationships and the importance of accountability. We are honored to be joined by Chantel Morin. Chantel is a master's prepared registered nurse, educator, and trauma-informed developmental care specialist with extensive experience supporting premature and medically fragile infants, families, and healthcare teams across NICU, perinatal, pediatric, and community settings. She's the co-founder of T.E.N.D.E.R services, an education and consulting initiative that helps healthcare professionals integrate trauma-informed, neuroprotective, and developmentally supportive care into everyday clinical practice. Chantel is certified by the National Association of Neonatal Nurses as a developmental care specialist and serves as a regional representative with the Canadian Association of Neonatal Nurses. Her work is shaped by both professional expertise and lived experience as an adult born premature and a mother of 3 children born preterm. Chantel is passionate about helping healthcare teams understand how stress, trauma, attachment, regulation, and relational safety influence the experiences and long-term outcomes of infants and families. Through teaching, speaking, and advocacy, she works to advance trauma-informed developmental care as an expected standard of practice, not an optional extra in neonatal and perinatal care. We're grateful you're here with us. Let's jump right into the discussion.
Chantel. I'm a registered nurse in Ontario, Canada. My background spans obstetrical and neonatal care for, this is like 23 years-ish now. But neonatal is my heart and my soul and my love. I spent almost 4.5 years as an educator in a community hospital. When I say community, it's very different from community down there. I'm talking like 8-bed centers, which is the average, 10 beds. Not yours, like massive 100-bed centers. We don't have any of those up here anywhere. So my heart's always been in the community setting. I'm working actually rural obstetrics right now. Some days I don't have patients at all. It's different for sure. I fell in love with trauma-informed developmental care when I had the honor of seeing Dr. Al's speak at a Canadian conference up here, and Dr. Paige Church as well, which then led me to Isabel Millette, which led me to Mary Coughlin, which led me to all you wonderful people now in the last 5-6 years, and just changed my trajectory. It's like, this is it. This is what I meant to do.
I would love to hear how the perception of whether or not you are seeing more families in the obstetrical and neonatal setting. I don't like the word refuse because it seems more negative, but decline what we consider to be standard of care, specifically vitamin K, vaccinations, declining moving for a C-section when the OB says it's time to go for a C-section, and whether or not you all are starting to see some of that same as well.
Absolutely. Yeah.
Okay.
I feel like not quite as much in the city and the larger centers. I feel like sometimes in the city, for the most part, it's like people want everything that you can give them. But moving down to a very rural center, I see more and more of no vitamin K, no erythro. Definitely those are the biggest things, but like even there's been some like no glucose screening test antenatally, no ultrasound. Yeah, there's definitely some rural populations that are declining what we know is best practice and standard of care for sure. In the city, I don't find it as big a thing. I mean, in my previous role, we still had to make the legal waivers and figure out all that paperwork because it was happening more and more. Where I work now and where I did work, like they're only 30 minutes apart. We were pretty much a pretty big epicenter for the recent measles outbreak in the last 2 years that happened up here. So there was a very large population and community that stemmed from. So definitely seeing more. And I feel like, even so our Nirsevimab, our RSV up here in our province at least became free for everybody, all babies born. There was no rules, no criteria, just if you're born this year, you get it. And we saw wonders in the city and we had pretty awesome uptake. And rurally, like the manager came to me, she's like, do you know why are our numbers so low? I'm like, well, I don't think it can hit them, right? Like Your numbers are also low for MMR, and your numbers are also low for McKay, like interventions, even like there's people that don't even want to be induced when they hit 41 and 4, 41 and 5.
So I know we've talked about this before, like we've touched on it, but that we talk about it from the lens of trauma-informed care and how we can try to communicate with our family from that lens.
I think it's a delicate conversation, right? Because it's easy for us to say, well, this is standard, this is safe, you let me do it, right? Without understanding intergenerational trauma, you have to be careful about stepping in it further, right? It's very easy for us to play that power play of like, well, I know this isn't going to hurt your baby, but they're looking at you going at a needle into their baby's, leg and being like, what do you mean it's not going to hurt my baby, right? So it's like this spiral that we've been on culturally. It sounds like in both countries, really, towards this just distrust in systems. And as somebody who has a healthy amount of distrust in systems, I can kind of get it. But then you want to get to this point of, okay, well, yes, but this part though is actually evidence-based and meant to be protective. But how we communicate about that, to your point, Tracy, I could come in and beat you over the head with a bunch of studies and a bunch of medical language and shame you into doing it. Or I could say, tell me a little bit more about your concerns,
Yeah.
right? So then we could find out, well, I'm worried it's going to hurt him. Okay, well, it is a skin breaking procedure, so I can't guarantee there'll be no pain. Here's things we can do to offer pain support for your baby. If they're able to latch, do you want to, you want to breastfeed while we do it? Do you want to help with hand hugs? We have sucrose, we have a pacifier. Would you like to, be a part of this? Would you like not to be a part of it? And kind of actively engage them in it rather than do what we normally do in healthcare and just like assault with information and walk away. It's easy to be judgmental when you're on this side of it. I think it's harder to try to take someone else's, have empathy for someone else's perspective.
Yeah. I actually had this really cool conversation, gee willikers, it feels like about a year back, with a physician who was part of the task force with the academy, about trauma-informed care. And she was talking about this very real existential crisis within medicine around trust and trustworthiness, for all of the reasons that you just delineated, but yet recognizing that problem and then not doing anything about it really makes you scratch your head and think, how do you think this is going to get resolved? And so, kind of thinking through that trauma-informed lens and thinking about all those principles, we have not, and I say we collectively, right, as healthcare professionals, we have not really fostered relationships that are grounded in reciprocal respect and trust and dignity and all of the, building relationships that feel safe. We've not really done a good job of that. We really do approach things like, I'm super smart, look at my alphabet soup, just follow my lead. And so I really think it's well past time, right, to just flip this paradigm upside down. And I think as nurses, for us, it's really, I think, an opportunity for us to really shine through what it is that grounds us in our work. That human to human connection, those, building those relationships that feel safe and, opening up the door for all those things that you just said, Jesse, for the questions and everything, so that we're not, dealing with these things in the moment when, we're potentially jeopardizing the health and safety of individuals. I mean, it almost feels like a two-pronged approach. We have to build that grassroots connected, safe rapport, but we also have to figure out how are we going to address things now too, because there's a whole bunch of folks that are already out there not trusting us and all that kind of stuff.
I think I've heard you guys talk before, and I think it's mostly you, Tracy, that's starting like in med schools and in nursing schools. And I was just shouting, yes, go Tracy. um, and I've noticed myself even being back at the bedside more now, it, the journey I've been on the last 5, 6 years, it's definitely changed how I practice and how I approach people. It's about giving choice, and it's about just telling someone before I'm doing something. And the odd moment, if I don't, like, oh, damn it. Like I catch myself and I'm like, oh, I wish I had done that, because again, we never know what's in people's backpacks and what they're coming in with to any situation. right? So just being there, being present, but not just assuming that because you're holding a blood pressure cuff that you're allowed to put it on somebody and
Right.
just do it to them, right?
Right.
And unfortunately, like even in either side, obstetrics or neonatal, I've seen the horrors of both. I've seen people just, and yes, it's an emergency, but people, no one's talking to the patient. They're just
Right.
doing stuff to her. And I remember being in this crisis once with a team and just looking around the room and stopping and grabbing this person's hand and looking at her. I'm like, I got you, because people were doing stuff to her and she was terrified and she had every right to be. Um, and even, last summer, my son was in the ER. He's fine. It was fine. And after a very long wait, we get in and gets his hallway medicine. I don't know if you have hallway medicine down there, but in a stretcher in the hallway and emerged.
Yeah.
And somebody literally walked up to him, did not introduce themselves, asked him a bunch of questions, did his vitals, and walked away. And he looked at me and like, his mom, who was that?
Yeah.
And I'm like, the only reason I knew who it was because I worked in the facility and their uniforms were color coded. I'm like, that was the nurse. He's like, oh, next shift comes on, same exact thing. And he's like, was writing on a piece of paper by a number, not like a name or anything. But like, he's like, how they didn't know who that's who I was, mom? Like, and this is a very well intelligible 19-year-old at the time. And he was just like, well, who was that? Like, and I'm like, if this kid
Yeah.
can pick this out, we've got a problem here. Like, and I think we just have to, I always try to remind myself, most of the women like that I meet, at least in rural care, this is the first time ever in a hospital.
Right.
And for many pregnant women, I think it often is when you were coming to that experience. And sometimes we do have to remember, and I think it does go back to that foundation of that education, that these people, nobody's an object, right? Nobody's a task to be done, and there's humans connected to the other side. And more the older I get, and still being in clinical practice, like, oh my goodness, people, like, this is a human in front of you. It's not a robot, and it's not a task, and it's not a checklist.
Right.
Like, where do we bring back the humanity to it?
Right.
Right, that part, right? I mean, I think anybody who has worked with me knows that one of my biggest pet peeves is when we're doing night rounds specifically, right? It doesn't happen so much during day rounds, but night rounds. It's like, okay, so who are your patients? And the nurse responds back, bed 7, 8, 9. I was like, oh no, you mean John, Jill, and Sue, right? Like, wait, no, like I'm gonna need you to give me names because you should know your patients' names. You will not refer to them when the parents call, at least I hope not, as the baby in bed 7. You will refer to them by their name. I really hope so. But then I think it comes this sense too, especially when we're talking families who have declined something, a family where the report was that they refused a C-section. So the way that the team referred to her from this point forward, everybody who talked about it was like, oh, that was the mom who refused a C-section. And I was like, wait a minute, wait, no, like, wait, like, no, right? Because we don't want to all have this negative connotation of her before we even meet her as a human being, as a mother. The sense of not referring to our patients by their diagnoses, by something that either in cases of adult patients they have said, or in our patients that their parents have said, really to me sets the stage, because I think, going back to the sense of meeting them as a human being and trying to understand their thoughts for why they are making whatever decisions they are making for themselves or for their child are going to be important to ensure that, and it all goes back to implicit bias, right? That we're not going into it with this biased sense of who they are or what their intention for their child is. And if we could just get back to the basis of assuming that everyone wants what's best for their child and for themselves, that is the mindset that I would prefer to go into my initial conversations. You want what's best, I want what's best. We have a shared mental model. Let's now figure out how to navigate to get to that end result that we both want.
Yeah, I was waiting for the N on bias because, like, that's all it is, right? Like, that's my lane here. But that's really what it is you have to ask yourself, is this truly clinically relevant information? Because really the clinically relevant information is that you had a C-section delivery with APGARs of X and now a diagnosis of this, right? Like, the other part really isn't actually applicable to the patient right now, And all it does is add context that isn't ultimately helpful unless they have the full story, because had they been a human to someone, they could have found the story. I'm glad that this patient in particular felt vulnerable and safe enough being vulnerable and sharing that with you. But imagine how much vulnerability is just required of patients with no reciprocity, right? It was one of my own struggles during my NICU stay of I had people that I had really strong professional and some even personal relationships with, and then they all of a sudden had access to all this other parts of my life that they wouldn't have normally had access to. And it was just this entitlement to know this. And I was like, no, that's not for you. Like, you don't get to know that part. Our level of relationship does not mean you have unlimited access, but that's what we expect in healthcare. We expect unmitigated, unlimited access to anything about anyone, whether it's their PHI, like literally their data, or their life story. And so it was really hard for people to hear, no, this one's not for you. I'm happy to talk to Laura about that, or I'm going to talk to my therapist about that, but I don't have to bleed my heart every time the shift changes over. And that's not a reflection of you, nor is it a reflection of me. It's a reflection of the dynamics that are at play here.
Chantel, thinking about, these kind of situations, but thinking about a rural setting, um, and I did a brief clinical stint in like a community hospital setting, and wasn't sure I was going to like it because I know I'm a bit of an adrenaline junkie. But what I discovered was that it actually was inviting me to develop another aspect of my professional portfolio. It was in the relationships, getting comfortable meeting strangers and trying to, foster some rapport. And I wondered if you might speak to that because these situations, this situation that Tracy brought forth, makes you start thinking about here's this poor woman. Nobody paused to try and understand maybe why she was distressed or what was the backstory. I mean, you, by the grace of God, were able to, begin to nurture a relationship that feels like that should have been way antenatal. Like, what, you know what I mean? Like, instead of just like, what's wrong with you and writing down all this, the facts, Jack. Um, I still don't know who you are, but in your setting, and to be honest, I think everybody's setting, um, where, this sounds a little judgy, but like, where are we dropping the ball?
I mean, we are dropping the ball. It's okay to judge people when they're doing things to be judged for. You can still judge from a place of empathy. I know that's my brand and what I like, the hill I die on, but like, it's okay to get called out for less than stellar performance because then you have an opportunity to learn and be better, right? We don't have to degrade a human being for a mistake, but we can say, hey, now this mistake has been made 5 times in all these different settings.
Yeah.
Perhaps this is more of a pattern and we can figure out a way to get around this. All right,
Yeah.
I'm going to let Chantel answer.
I love that. Thank you so very much. Where are we dropping the ball? Meaning we, all of us, right? The system and the individual.
Yes, because I've actually found myself blogging about this a little bit more again lately. And in conversations with colleagues that have a regional role. So they go to probably 6 to 10 different hospitals of different levels in the region. So they really get to see everything. And she's just like, oh my God, we need you out there. Like, someone out there because like and I know we've all said it before, people say, we do trauma informed care. And we're like, but do you? Right? Like, and I think that's where, and I wish there was a magic answer out there. And of course there's not, but education, I think, needs to start in schools, number one, not just for nurses, but physicians and everybody,
Yeah.
about why this is so important and why this is not fluff anymore, or the soft skill. I've heard that said recently and it was like, oh, ouch, right?
Mhm.
Really, we're still thinking it's the soft skill, like that it doesn't matter as much as ABCs. Like, there's no accountability out there. And that's, when you get talking about it, that's what the part that breaks my heart. Like, um, so I'm Ontario based. Nurses in Ontario do not have to submit any continuing education credits to get their license every year. Every province is a little bit different. So there's nothing to hold anybody from ever taking another workshop or doing more schooling. We still have many in our system that are diploma nurses and I mean, God bless them. They've got some amazing skills and they're amazing people. But so we've got this mixture of diploma and bachelor programs. Plus, we have two categories of nurses. We have our RPNs and our RNs, like an LPN, I guess,
Yeah.
similar as well. But their scope is very gray now between the two. There is no clear definitions anymore. So that's like one level of things. And then there is an organization in Ontario that put out neonatal nursing standards. And I was so pleased they referenced you, Mary. You know, the language is great. And they reference like trauma-informed care, like and truly and how it's meant to be taken. So great, here's those standards. Who's holding anybody accountable to those standards from a individual level, from a unit level, from a systems level? Like there is nothing because, you know, and I think that, you know, and it's one of those things, if we don't measure it, do we not care about it? So only, so our level, we all have to report it. I know level ones or threes and twos here do have to report all the same stuff in terms of your class B, unplanned extubation, how many lines. Level twos don't really do central lines here, maybe a little bit. You know, those big indicators, right? That's all that's reportable.
Yeah.
Like, so nobody's reporting skin to skin time. You know, even just recently, a former colleague from another city had a third baby and, you know, shared on socials, and I reached out because it didn't sound like it was the greatest experience. And she wasn't. She was an IUGR, 35 weeker. So she was an early preterm baby. And she said, Chantel, it was awful. She was denied skin to skin. She asked about 20 times. Here she is, like again, a master's prepared registered nurse. It is 2026. And she was told no because the baby was on CPAP. And then you're looking at me like, what? And I'm like, that still happens. Yep. Like, and I'm like, do you have a test tube? And like, even like, and I said, my God, even the CPS, our Canadian Pediatric Society, says there is very few things that outweigh the benefits to the risks of skin to skin care. That statement is out there, and oh, like it just hurts my heart, like that it still happens. I mean, it happened to me as a mom almost 18 years ago with my 34 weeker who was off CPAP when I asked for skin to skin care, and I was still told no for 12 hours. And 18 years later, damn it, that still sits with me. That I knew better then that skin to skin was important, and I was told nope.
Yeah, we've been traveling around doing some sims on skin to skin, and it's when I first come up with the idea, I was like, is this really needed? Do we really need to use simulation for skin to skin, right? Because it's just so natural to me,
I think we do,
right?
though.
But then I started doing them and I was like, oh, we really do need them, because I find that there's just a lot of healthcareisms that get put in the way that are really, quite honestly, fairly arbitrary. You know, I don't think they're necessarily mean to be harmful, but they are, right? Because intent and impact are not the same, as we've said before. And it'll be something like, well, I don't allow patients to hold with an umbilical line. I was like, well, is your umbilical line like well secured? Do you have a film? Is it moving? Like, is everything okay? Is it draining? And they're like, well, no, I mean, the line, it's fine. It's just the fact that it's a line. And I was like, well, that's not a reason, you know, to do that. And then they just look at me like, well, what do you mean? And I was like, I mean, if you're really concerned, you could do side lying skin to skin. Like that's still benefit, like to where you can visualize it. I was like, as long as the baby is appropriately positioned. I was like, but really and truly, they're fine to go chest to tummy, just like everything else. Well, the parents are dirty. I was like, well, so now we get into a whole other different problem, right? Because now you're coming in here thinking the parents are just dirty and that they're going to willingly give their child an infection when most hospital acquired by definition, right? I was like, when you're thinking of like a hospital acquired infection. And then she, you know, eventually backed down, but it was like, okay, we do need to continue to be this voice of reason, even though it might seem like I shouldn't have to do this, you know? But sometimes it's comfortability. It's, I'm new. I've never seen this. I've never done it. This is terrifying. I have a tiny intubated person with a really important line, right? And I can validate all that. We can practice though, and we can learn some skill.
Mhm.
Or it's, no, I just don't do it because like one time 30 years ago, something bad kind of happened to the kid three beds down. So now I don't do it. And
Yeah.
you're like, well, hold on, what a legacy that is like of harm really for every other family that you've seen. So it's just sad that we've gotten here, but I think we've gotten here for a lot of things, not just skin to skin, but for a lot of
Oh,
skill acquisition, regardless of how you want to talk about it.
It's just really interesting because actually I take both of those statements that you just made, Jesse and Chantel, right? The fact that Chantel said that 18 years later, that still sits with you, right? And Jesse, you made the comment that we do certain things because of some small thing that happened 30 years ago. And here's the interesting dynamic that I see with those two things is that I guarantee you, if we ask that nurse who said no to you, to them, it felt like a small thing, right? It felt like well, this is just how we do it here. But then as a parent, that still sits, right? And you still remember that moment and you still remember probably that nurse's face, if not name, right? Because that sits. And I think that as nurses, as providers, as people working with families, if we could stop and think about the fact that what seems small to us resonates with these families for long lasting implications, right? And we think that it is not that big of a deal. And if we would just pause, there's got to be some balance, right? That we recognize that what feels very, very minor to us 18 years later, this family member can come back and say, that nurse told me A, B, C, and D, right? And there's potential for that to color every other interaction that I have with someone in healthcare. And it could be just that tiny little drop in the bucket that was a blip on our radar, but now has the potential to impact how I see every other physician that I work with, right?
Yeah, I tell people all the time, like, this is your 12-hour block of time. This is your shift, but this is this person's existence. This is their family. This is their day in and day out, especially in the NICU when we have long stays, right? Even when things go well, you have a long stay. And so you're coming in and out in an episodic adventure of just like, this is my 12 hours. I'm going to get through these 4 care times and I'm going to go home, right? And maybe you've got your own stuff you're bringing in with you, like we've talked about before. You're bringing in your own, trauma or things that are going on in your personal life that is also valid. But you can't set that at the foot of the parent who is actively in their own trauma story being like, yeah, but mine's more important than yours. And I don't have it in me today to do that. So we're just going to say no, right? But it's recognizing that we have such a power if we choose to yield it for good rather than convenience for ourselves, because that's usually how it ends up going. So then it's holding all the systems that we intersect with accountable so that we have more capacity to use this power for good and not evil, right? Because it's really easy to say, you know what, it is a lot of work to get a 24-week person who's intubated with a umbilical line. It's a lot of work to get them out, right? And it's also not without risk, right? We know that when you have a population where you have a tube that is barely, in their tiny little trachea that's taped to their face, you do run the risk that is non-zero of an unplanned extubation. Those risks are all insurmountable. They're not insurmountable though. Like we can get over all of them. We just need to have a team who's willing to do those things despite it feeling like an inconvenience, right? As a nurse, I never felt that way. I always thought it was like magical and I was kind of like selfishly loved being the one who got the baby out because I was like, oh yeah, he's got 2 chest tubes. That's okay. They're sutured. You want to get him out, you know?
Yeah.
Because I loved this moment of, that connection. It's like magic, right? You can like feel it in the room where everybody's just sitting there. And I just always felt so privileged to be able to facilitate that connection for parents. And maybe that's a flaw for me, but I was like, I was known as like, oh, she's going to get him out of this bed. And I was like, yeah. So when my own daughter was in the NICU and she was like, I don't do this. And I was like, you're going to, right? So like, what do we need to do to make this okay for you? Because it's going to have to happen.
I love the way the conversation's going. You're making me think of so many different moving parts that we often don't acknowledge or address. Chantel, you mentioned about education, right? I mean, and that is a fundamental backdrop, but also kind of coming to Jesse's point, and the skill building of how you operationalize it, because just because I've got all that knowledge in my noggin doesn't necessarily mean it's going to come out my fingertips for a myriad of reasons. And it might be fear, it might be lack of skill, competence, and being mindful of not being shamed into doing something that pushes me in a direction that makes me feel even more unsafe. um, and of course, the system that we work and live in also kind of sets a tone for this very performative approach versus kind of, Tracy, what you were alluding to is versus the presence piece. What I think one of the skills, to come back to kind of a sim approach, is helping people see the connection of those things. How do I weave presence into my performance? Because there are a lot of do's that are part of my job, but how do I build presence and competence into those performative pieces so that I'm not stripping the humanity off of it, I'm actually weaving it back together. A little side trip. I had this wicked awesome opportunity to do a educational thing. And it was all around skin to skin, and it was for parents. It was sponsored by the National Parent Organization. And so, there was a heavy focus on parents, which I thought was absolutely brilliant, because I thought, hey, if these nurses, and no shame or shade to the nurses, but if these nurses don't want to do it, that was my mindset initially. If they don't want to do this, I didn't really dive into all the different reasons that they had behind not wanting to do this. Then we're just going to force them to do it, because all these parents are going to they're going to take the course. And we did the sim. We had them do the baby, and we put tubes and lines on them, and we had them do a standing transfer. We showed them how to, how the flying through the air transfer, all the different things. And then they got a little certificate. But then, as this was kind of unfolding, you start talking to the nurses, and it really was all of what you described, right? I'm scared. I'm afraid. I have these other worries about safety, stability of the line, the ET tube, blah, 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 blah. And so we then, flipped the script and did competency training for these guys as well. And it almost feels like an opportunity. I mean, that's a very procedural kind of a task, if you will, right? I mean, like moving somebody into skin to skin. But what about the other things of like, how do you welcome a family into the next nightmare phase of their life, right? How do you sit down and have somebody feel safe enough to maybe at least begin to share part of their story with you? You know what I mean? Like those, how do you have those difficult conversations with, grouchy Gertie who's resisting all of these things? Like there are core skills that I think, because we're human beings, we make assumptions, and you know what they say about those things. We make assumptions that, like, oh well, they'll figure it out. But why compromise a sacred moment by crossing your fingers and praying that somebody will figure out how to be nice or kind or respectful or supportive to somebody else, instead of saying, these are the rules, this is how we play here in community hospital X, in level 4 Y. These are core fundamental elements to kind of come back, Trace, to your question about framing this through a trauma-informed paradigm. I think having tippers is wicked awesome, but I think that there are also just core human capacities, I don't know if that's the right word, that instead of crossing our fingers and hoping that people can operationalize them, because to your point, Jess, people are coming with their own story and their own crap, and maybe struggling to compartmentalize that stuff as they show up on the doorstep of somebody else's nightmare. So it feels super complex, but I think in a community environment, it feels like, because you said, and I remember this, there were days when it's like we didn't have any patience. Well, what are we going to do? Well, let's go clean out the storage closet, or, let's go do something else, that feels performative, and important in its own right, versus let's start to identify what are the human competencies, the human caring competencies. What does dignity look like in a conversation, in a high acuity setting? Do you know what I mean? Like those kinds of things feel like they could be maybe begin to chip away at that?
I've got three things that have come up now in
Yeah.
all of this. To the most recent one, actually, it was a conversation with a dear friend who, funny enough, we worked together over 500 kilometers away from here now. We work together again. We both moved back to the area at the same time, and she's just lovely. And, and we've had that conversation a little bit of, I don't know, we didn't call it trauma informed care, but, she even named it. She's like, you and I are so similar because we have the emotional intelligence. I think we were talking about how some other people reacted or handled situations. And she's like, you and I have got this because we've got that emotional intelligence to be able to do it, sort of thing. And I was like, I never really thought of it that way. And it's like, yeah, that is a big piece of it, right? And I think that is part of, I guess, that humanistic quality that maybe sets some of us apart from the people that are just a little more maybe procedure. Not that they can't get there by any means, but again, you don't know what you don't know sometimes. And how do we support people to get there? So that was definitely one thing. And then Jesse, you talked about like, all these families that have the long length of stay and stuff. But I think it's really valuable to look at the ones that don't. And it doesn't mean it's not any less traumatizing. Like my NICU stays with my kids were 5 days and 8 days. So can we imagine some people that might be nothing, but it wasn't nothing for the people that are living it. Even the full term babies that go in maybe for a day and a half for hypoglycemia control.
Yep.
That's still not part of their plan. Like, I think it's me and Malcolm that says the best, right? Nobody gets pregnant, says, I want to go to the NICU. Like, it's not part of anybody's plan to have that happen. And I think that's that fundamental thing when we're training people in the NICU is to even say that sentence, like, nobody wants to be in here. So just think, maybe put yourself in your shoes to some, a toe in the shoe if you can to some degree to just stop and think about where they're coming from. And no matter what, like, I was an OB nurse in my NICU experiences, not technically NICU trained at the time, but it didn't mean I didn't have some knowledge and background, just like my friend that, had it too. And then here we are, big, strong, educated women advocating the health out of everything for our kids and still not being successful. So then I just imagine like the people that don't have that knowledge or that courage to speak up, and that those are the ones that are silent or the ones that we think don't show up because they're scared to show up or they're scared to say anything. So I think just that piece too. And then the other part about Samir, I mean, I'd be amiss if I didn't talk a little bit about T.E.N.D.E.R at some point. So T.E.N.D.E.R Services is a business of my lovely co-partner, Isabel, and I had the honor of our first take art, like she's been doing this for a very long time. I'll give her that. But I got the first full training that we do for 4 days in a pretty big unit. I think they had 60 beds. And so we gave everyone a theory for the day. So we wanted people to understand why we were asking them what they do the next day. And they did pick their champions. So the people that, that were keen already. And the transformation in these staff in 3 days, it was so amazing and excited to see when we took them to the bedside and said, just stop, look what this baby's telling you, and just the light bulbs that were clicking, and how they immediately then told their part, like by the afternoon, we're coaching their colleagues, oh no, we should do it this way because of this now. Well, look, this baby's already telling you this, and like the monitors, and it was just like, this is what is needed. Like this is like, oh my God, if I created a dream job for myself, it would be that hands-on person, at least somewhat Monday to Friday. That's that trauma informed specialist that is with the parents at the bedside and supporting the nurses to get to that practical side. But they don't teach us that. Like they may talk about the theory, but no one's teaching you what to do, how to look at that baby, how to stop and listen to that baby. And I'm not asking you to spend 10 extra minutes with that baby. I'm talking you to take a breath for 10 seconds, give that baby a moment and proceed and recognize the impact that has down the road. And I mean, I could go along into that. Tracy, you don't know this about me, but I'm a 27 weeker from way, way back in 1980. And I still look at Mary some days and I'm like, how am I okay right now? But I have my issues, right? Like, I'm very grateful physiologically or physically to be well. But there is definitely things that have stayed with me because of prolonged hospital stays and attachment and all the things, right? So And I think that's what fires my soul is also that 30, my middle son, that 34 weeker who's almost 18 now. Um, never you would never know what to look at him that he was preterm or had challenges or issues. Um, but when Dr. Page Church presented and put up this list of all the minor morbidities that nobody talks about either because it's not on a Bailey score, and I was like, check, 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 check. Oh my God, that is my kid. And you're telling me we know this is back in 2008. No, sorry, the conference was not in 2000. He was born in 2008, but like in 2019 or 2018, there is now things we know that can mitigate that, lessen that. And other parents don't have to go through what I've gone through with this kid over years and years and years. Like, damn it, I gotta tell the world now. Like,
But on that same note, because you said something, you said I wouldn't know that you were a 27 weeker or that we wouldn't know that he was a 35 weeker, right? That to me, again, I think speaks volumes for us not saying that about our patients, right? Because at the end of the day, you are Chantel. You are not that 27 weeker. So it goes back to that conversation of knowing your patient and their families for who they are as people. Now, the importance of knowing the potential complications that come along with that diagnosis. But I first want to know who you are as a person. And then the other conversations come up, right? But that to me, I think speaks volumes for the fact that I would not know that had you shared that with me. But that is the label, for lack of better words, that we put on our patients, and that is how we navigate through their state with them versus saying, "This is Chantel. This is my patient for today." Right? Who is she as a baby? She's a baby who likes to pull her tube out, right? Or something of that nature, right?
apparently, I was the baby that got tangled in the saran wrap that they used to have to put on top of the incubators, this whole a backflip forward backflip to keep the heat in.
I
So
love
I was the
that.
baby that was getting tangled up in the saran wrap,
I
apparently.
love that.
Yeah, I love the touchstone that you had about just like the fierce advocacy, right? Because I think that's something that we all share from all the different lenses. Is, now we know this. Why is this not earth-shattering to everyone else?
Yeah.
Right? It's like you turn around and you look around and you're like, okay, we have all these publications, we have all this information, and I was moved to change and maybe be curious and learn more, but it doesn't seem like all of my peers followed that cursory, that change in path. So you're just like, it gets frustrating sometimes on the advocacy front because you're like, how many times are we going to say that the baby is a person? And at some point, I want to be able to say it and everybody be like, well, yeah, of course, right? But like, I have yet to have that experience now.
Mhm.
Maybe one day, right? If I do it long enough. But it's like, it's evidence that the work is still needed to the point that you made, right? Like, you're like, I see this happen. But then you're like, okay, but also, when do we get to cross this like magical threshold? And maybe I just won't live to see it. I mean, that'd be wonderful. I hope I'm planting seeds for like generations to come of that change. But it would be so, I guess, validating, or it would just feel so holistic is the word that keeps coming up. Like if we could finally turn that, like make that turn.
I did ask a group of students the other day how many of them had heard the term wimpy white boy, and nobody raised their hand. I was like, oh,
Oh.
right. That was my response too. I was like, oh, we may be doing something here. Like we may be making change. And they looked at me almost like they were almost offended that I said it. And I was like, that is the correct response. You should be offended by that term. Thank you. We are making change, y'all. And that was a small
Okay, okay. I'm gonna
number.
stow
Here.
that one
But
away when I'm feeling
Yeah.
sad.
yes, I
Yeah.
was so excited for us.
But it's all good, to be able to have people join into the circle and to share their experiences and to give their own perspectives, whether it's their lived experience or professional or both in this case, to be able to join and kind of share with the people out there listening, to us, whoever and wherever they are, that maybe this is making a difference, to Tracy's point. If people are, sitting there and going, hey, I've never heard this term that, we're glad they've never heard before, then maybe somebody out there is doing the Lord's work, right? And we're just helping make light work of that.
Well, thank you all for inviting me into your circle. I'm completely honored. And if anybody can take anything back, it's just, I guess, one day at a time and 1 hour at a time. And just, I think the most important thing is no matter who you're working with or what population, what you do matters. It truly does. And what you say matters. And just if everyone can just take that pause. And I really think a lot of people out there sometimes just need to remember why we do this and why we're here. And if you can go back to your 18 or 20-year-old self and remember what sparked you, and you can find that again, that's just what I hope for everybody. And if you can't, then maybe it's time to reevaluate a little bit, because you are making such an impact on the youngest and the tiniest of people, but also those families, and you're sending those families out into the world to grow these people and who they become. And these are the people that are going to become a part of your community and my community. You know, maybe one day we will shout it out to the world, and it'll just be I hope it becomes part of what we do and not the nice thing to do anymore. So
I think we're moving in the right direction, my friend. Slow and steady wins the race, right?
yeah.
Yes.
Literal baby steps.
Yes.
Literal. Yes. But thanks for joining us. I know you've
Oh my
got
goodness, it was
a lot going on, but we're happy to have you.
oh, my pleasure. I was honored.
Timeless Topics is Jesse Barnes, Tracy Bell, and Mary Coughlin. It is produced by Jesse Barnes and music from Carlos Bell. The thoughts and opinions shared here are those of the individual speakers and do not reflect the official policy or position for any of the speakers' employers or any other affiliated individual or entity.